the trachea or the windpipe. So it is going to go all the way from the bottom of the larynx to where it branches right here. And it is a flexible tube, right? But it's still slightly rigid. And the thing that's going to allow it to be rigid is going to be these C-shaped cartilage rings that's going to be found around it. So if we take a look at it right here, here's the esophagus. So this is the back part, and see the esophagus sitting back there. But look, you can see the cartilage right here. And there's none in the back, so it's literally going to be shaped like this. We can't see it in the back right there. I wish they would kind of flip it around and show us. But these cartilages are really important because they're going to allow the trachea to be patent, stay open at all times because we want to be able to breathe, right? Yes, we do. But it's also important that there's no cartilage in the back because it's going to allow the esophagus to be able to distend whenever we are eating. I guess sometimes drinking as well, because usually the esophagus is completely closed. What else on here? You have the trachealis muscle. That's going to be important, like with coughing. I mean, it's very important. But one thing, one of the functions that we've mentioned is, or one of the reflexes we talked about was coughing reflex. So the trachealis is going to be kind of important for that whole coughing reflex to kind of close off the end of the trachea to help with coughing. Let's talk about this carina. This is the location of the carina. It is going to be right before it splits, that trachea splits into the primary bronchi. This is going to have lots of nerve receptors here. So it's going to kind of pick up any kind of irritants, or it's going to pick up if something is trying to go down that way that shouldn't go down that way. So that is going to be the importance there. As far as mucosa, again, pseudostratified ciliated columnar epithelium, still here. Remember, it switched in the larynx. I forgot to mention that. Remember that the superior portion of the larynx is still that stratified squamous epithelium from the laryngopharynx, but the inferior portion of the larynx is going to be pseudostratified, and so is the trachea as well. Other than that, there's not much difference. Of course, you have cartilage here. This is where we are going to have the C-shaped cartilage rings. The adventitia. This is something that we haven't talked about yet. Adventitia, which is going to be kind of an elastic connective tissue. All right, from here, we are going to start to branch into the different lungs. So that is going to bring us to this bronchial tree. The bronchial tree is going to be where we have these progressively smaller branches that are going to occur. I guess progressively branches into narrower tubes. That's what it says right there. So remember, we're still in the conduction path, the conducting zone. And as you can see, you are going to have it branch off into something called the main bronchi. You have two main bronchi. These are also called primary bronchi. And the reason why, it's because of the fact that it's going to be, I guess, the first branch that you're going to have here. So you can call it main or primary. I usually refer to it as primary, so I think it's just easier for students to remember that way. So you have two because you have two lungs. And then it's going to branch into smaller tubes called the lobar. That's the blue ones, the lobar bronchi. Another term for lobar is secondary bronchi. So lobar gets its name is because this is where it's going to start to dive into the lungs. The primary bronchi, most of the primary bronchi actually sit on the outside of the lungs, and then it's not until the branch into these lobar where it's going to dive into the different lobes of the lung. And we'll talk about how, on the right side you have 3 lobes, on the left side you have 2, so that's why you have 2 and 3 lobar bronchi or secondary bronchi. And then look at the yellow ones, you're going to have even more because, again, more branching, smaller tubes. The yellow ones are called segmental bronchi or tertiary bronchi. They're called segmental because they go into the different segments, these bronchopulmonary segments that we're going to talk about of the lungs. So again, we'll get to that later on. And look, even smaller bronchi after that. I think there's like 9 to 10 degrees of branching going on in this bronchial tree. So that's a lot of branching. From here, from the smaller bronchi, they are going to eventually turn into the bronchioles. And really, so let's take a look at this and talk about the difference between, look, you have the cartilage of the trachea, you have all of this cartilage here of the primary bronchi. Look what happens in those secondary lobar bronchi. It starts to become irregular, that cartilage, right? And then as we get to the segmental and the smaller, even less and less cartilage, that's one of the main differences between bronchi and bronchioles really is one's going to have cartilage, the other is not. Bronchioles do not have cartilage, not at all. So that is going to kind of differentiate the two. What bronchioles do have more of is more smooth muscle. So yeah, these guys have smooth muscle, but these are going to have a thicker layer of smooth muscle, these bronchioles, which is really good because this is where we are going to have this whole bronchoconstriction, bronchodilation that's going to occur. And this is going to help regulate airflow. Like whenever we have irritants that are coming in, these can go in and bronchoconstrict to make sure that irritants don't go all the way down to the alveoli. So you can kind of think of these a lot like your blood vessels and how that is going to decrease airflow if you do that. But then if you open them up with bronchodilation, that's going to increase airflow and help get more air down to the alveoli. So we'll talk about this whole resistance and airflow later on in a different segment. What else? I think that's about it on these as far as kind of the branching. This is where we turn from the conducting zone to the respiratory zone, which is what we're about to get to after we talk about bronchitis and asthma. So bronchitis is exactly what it sounds like, inflammation of the bronchi, and it can be from inhaled irritants like cigarette smoke or vaporized chemicals, or it can be from a bacterial or viral infection. Anything like that can cause this. So what happens is, look how thick that wall layer is going to get because of it. So remember, itis is inflammation of, and look, it is causing inflammation of that mucosa. But another thing is anytime the mucosa is inflamed, it just wants to secrete so much mucus. So it is going to produce a whole lot of mucus, so the bronchi are going to get kind of clogged up. So you tend to cough a lot with bronchitis because your body is trying to get this mucus out of here and get it up to swallow. You can have sneezing, pain with inhalation and fever and things like that. With acute bronchitis, it usually resolves hopefully within a couple of weeks. But, and acute bronchitis can come along with a cold or a flu. Isn't that just great? So so you can have that because, again, look, it talked about bacterial or viral infections. Chronic bronchitis is going to be where you have bronchitis for a lot longer, lots of mucus being produced, and because of that, you have this cough that lasts longer than 3 months. And it usually chronic bronchitis is from cigarette smoke, but it can be from other things as well. Look at that, occurs after long-term irritant exposure. A lot of times the epithelium changes because of it. So you have some permanent changes to the bronchi that can occur in here. You can also have your cilia, and the cilia kind of gets clogged down with so much mucus. And that's another reason why you start to cough, is because of all of this mucus that you produce. It weighs down the cilia, and so they get to where they can't sweep anything up, and that's why you start to cough so much. Another thing that comes along with cigarette smoke is it paralyzes cilia, and eventually it destroys the cilia as well. So if you have all of this mucus that is just hanging out that you can't cough up, then you're going to have more pathogens that are going to reproduce because of it. So let's move on and talk about asthma. I think the new edition of the book has, it's a little bit different. It adds in more about exercise-induced asthma, so you might want to go in and read about that if you're curious about it. But asthma is going to be a chronic condition, and it's whenever the bronchioles undergo these kind of bronchospasms to where they are going to kind of bronchoconstrict. Again, it has to do with being exposed to these different irritants or exposed to allergens or anything like that. And remember, I talked about how anytime that your body or your bronchioles are exposed to that, it wants to bronchoconstrict, and that's exactly what's happening here with people with asthma. So this can be triggered, asthma can be triggered from if you catch a cold, a virus, any kind of allergy. It can be exercise induced. So there's a lot of things that can go in and trigger asthma. Look, cigarette smoke, again, another irritant that's going to happen. So you have a lot of similar effects that you have with bronchitis. It's going in and causing this swollen mucosa, look, swollen submucosa, lots of extra mucus that's happening as well. And of course, with this, they are going to have issues with breathing because this is going to go in and decrease airflow. So we'll talk more about that whole issue with airflow and resistance later on. One of the main things that people that do have chronic asthma that have to take a prophylactic inhaler, which I mean an inhaler you have to take every single day, it's usually going to have cortisone-related compounds, some kind of steroid, and it helps go in and reduce inflammation or just not ever allow it to happen. Or individuals that have issues with asthma where it gets a little bit worse, then they can take a rescue inhaler. Usually the rescue inhaler has some kind of like epinephrine in it that's going to go in and help cause bronchodilation or something like that. Or if it's still really bad, if you can't get it under control because maybe you just got over a cold or something like that. I know my son, he tends to get pretty bad asthma attacks or asthma episodes after he's been sick for a little while because of a virus. And that's, if it's really bad, then the doctors will give them doses of steroids. They can also have nebulizers. So if you have an asthmatic at home, or if you are an asthmatic, then you might have, your 2 different inhalers and your nebulizer at home. And sometimes it doesn't work and you have to get some doses of steroids that are going to help go in and reduce that inflammation. All right, so let's take a look at the respiratory zone here. Remember, that's respiratory ducts, alveolar ducts. You have these alveolar sacs and alveoli. Remember, the epithelium here is, we've been changing. I forgot to mention that. Whenever we get into those bronchioles, it starts to change. It goes from like a simple columnar, and here in the respiratory bronchioles, it's going to change into a simple cuboidal. By the time we get down here to the alveoli, we have simple squamous. It's exactly what we want, very thin layer for gas exchange to occur. So alveoli, there in each lung, there's going to be 300 to 400 million of these alveoli. So that's a crazy amount. And the reason why they look like this, why we have these structures that are basically they look like grapes. So this is like a grape, a bunch of grapes. And if you get your grapes at the store, then they're going to have little stems on it that you pluck it from. And then there's going to be one big stem, right? So it's like the respiratory bronchial, and then the alveolar ducts, and then you're going to have your little alveoli after that. So they look just like, your respiratory zone is just like a bunch of grapes that you have at home or at the supermarket if you don't like them. If you don't like them to be at home or anything like that. There are going to be these pores, let's take a look. Yeah, these little holes that are going to kind of connect the alveoli. They provide collateral ventilation, so if something happens to one, then they can all kind of communicate with one another, and gas exchange can occur from any of those alveoli. But the reason why, I digress there for a little bit, the reason why we have so many of these grapes and not just one big giant grape, it's mainly for surface area. So look, if I have this one big giant grape, I don't have a lot of area to go in. I have some for gas exchange, but look, if I go in and have a whole bunch, I am adding so much surface area in here. So you can increase this surface area by so much by putting in these tiny little structures, right? And it's a lot better because if one alveoli dies, then you have a whole bunch of other ones. But if you had just one big giant alveoli and that died, then that would cause more issues. But it's mainly about surface area. More surface area means that you have more gas exchange occurring. That's exactly what we want. Look at all of the capillaries that are covering the all of the alveoli. There is some over here as well. They just took it off so you can kind of see what it looks like. What else? So this is going to be a cross section of it, and I don't know if you'll be looking at the same exact one in APR, but something like that. Look, you're going to have that opening to the bigger respiratory bronchiole, and it branches into the smaller alveolar ducts. And then you have the alveoli that are going to sit at the end of the alveolar ducts there. So let's look at what alveoli are made of. I mean, I've talked about how they're made of simple squamous cells, those really flat, thin cells. That's about 95% of the cells in the alveolar wall are going to be these type 1 cells. The rest are going to be type 2 cells, septal cells, and these secrete something called pulmonary surfactant, which is going to be kind of a combination of lipids and proteins, so it's an oily substance. If we looked at the inside of an alveoli, there's actually lots of water kind of coating the walls. And remember with water how they love to like hydrogen bind to one another, cause hydrogen bonding, I guess I should say, not hydrogen bind, but hydrogen bonding. And when that occurs, it creates a surface tension. So we'll talk about, we want some surface tension, but we don't want a whole lot, because if we do have a lot of surface tension, it's going to cause these alveoli to completely collapse. So what we want is the surfactant is going to come in here and break up the hydrogen bonds, and it's going to make sure that the alveoli stay open or patent. So that's a really good thing about that surfactant. Also, we are going to have these little dust cells or alveolar macrophages, these permanent macrophages that we have specifically here for the lungs. Here in the alveoli, they are going to do exactly what all macrophages do, is eat up any kind of pathogen, any kind of dust, anything that has come all the way down here. It has made it this far. So now what we're going to do is we're going to zoom in. Let's take a look. I'm going to zoom in on the wall that's happening here between the alveoli. It doesn't want me to draw it. Between the alveoli and the capillary. So let's look at that right here. We already know that we have a simple squamous epithelium over here in the alveoli. And remember, blood vessels, simple squamous epithelium as well. So that is perfect. Gas exchange material, as thin as possible, so oxygen can go from the alveoli into the blood, and carbon dioxide can move from the blood into the alveoli. You have a fused basement membrane in there as well. It's not too thick. Again, want it as thin as possible. So that is a huge characteristic of the respiratory membrane, is the fact that we want it as thin as possible. So we'll talk about some things later on, what can cause issues with gas exchange once we get to that whole gas exchange part. So we only have one organ left, right? We have the lungs, and that is going to be our next discussion. So until next time.